Hi, everyone, and good afternoon. Welcome to this week's DIS COVID information sharing call for April 7th. My name is Leandra Lacey, and I'm the Senior Manager of Capacity Building and Member Engagement here at NCSD. Thank you so much for joining today's call. DIS are a crucial piece of what is happening nationwide with COVID response, and NCSD is so happy to provide you all an avenue to learn from one another and share resources. Before we get started, just for some housekeeping, there is a slide that you'll see on your screen with audio instructions for either having the system dial you or dial into the system. All attendees are muted. Your lines are muted to ensure clear audio, and this meeting is being recorded and will be shared. If you want to unmute yourself later on to ask questions or share any insight, you can press *# to unmute yourself on your phone. You can also use the chat feature that's on your right-hand side to submit questions for our presenters and questions for one another. And you can also use the chat to alert any of the hosts for technical issues that you may come across. Just a reminder that this call is held weekly on Tuesdays from 3:15 to 4:15 Eastern. And NCSD will continue to send out registration links and reminders for the foreseeable future as we're holding these weekly calls. So now I will kick it over to Brandy to give an overview of our agenda for today.
Hey, hello, everyone. This is Brandy. I am the DIS Committee Chair, and thank you again, as Leandra mentioned, for everyone being here today. And then also can't thank NCSD enough for, what they're doing as far as bringing these calls to us each week as far as the DIS being on the front line for our COVID response. So as every week, we do have a specific topic in which we will discuss certain things as far as COVID response in relation to the DIS. This week, we have Zant here from Washington, and then also Diane Pratt, who will be on the call with us today to talk about contact tracing. So I want to go ahead and pass this over to Matt, and he'll go ahead and kick us off.
Hi, everyone. This is Matt Pryor. I'm the Director of Communications here at NCSD. Thank you, Brandy, for your service, and thank you to everyone on the line for what you are doing every day in our nation's fight against STDs and in coronavirus response. I just wanted to give you a few updates on what we're doing here at NCSD. And hopefully you all have seen our COVID Command Center. If you haven't, I will put a link to that in the chat box. But that is basically all you need to know and all the information and resources gathered for STD programs to respond to coronavirus. So there's a number of sections, including a section on state and local STD program response, DIS program response, and there's a number of resources that have been shared from CDC as well as your colleagues from around the country. If you do have any resources that you can share, for example, Zant Bryan from Washington, who we'll be hearing from in just a moment, shared a contact investigation training that Washington State Department of Health developed. So anything like that you want to share, please do reach out to me or anyone at NCSD. We'll make sure that it's posted on the Command Center and your colleagues have access to that. To supplement the COVID Command Center, today we launched a new communications vehicle called the COVID-19 Command Center Alert. This will be a multiple times a week newsletter containing updates from the field, resources, and more to help our field respond to COVID-19. You can see we brought on Erin Fratto as our COVID response consultant. Erin is a former STD director from Utah. She's one of us, is a former DIS. She gets how this stuff works. She's been reaching out to states and cities and other localities to find out what it's looking like on the ground. So if you have anything that you want to report from the field, any stories about your jurisdiction's response, please reach out to Erin. She's here to support you in your work, as is NCSD. And keep an eye out for that COVID Command Center alert that we'll be sending multiple times a week, as I said. A few things I wanted to point out. This week, at the end of last week, we shared a resource called tellyourcontacts.com. Tell Your Contacts is a supplement to a website that we manage called Tell Your Partner. in partnership with the Building Healthy Online Communities organization, and it's basically a resource that was intended to be used for partners to notify their partners that they may have been exposed to a number of STDs. That has been expanded to coronavirus now. So if someone may have been, someone tests positive for coronavirus or COVID-19, they're able to tell their potential contacts that they too may have been exposed to that infection. It's a really cool tool. I would encourage all of the DIS and all STD programs to check it out. It's ready-made, so it could be a very useful tool in the toolbox. In terms of communications here, we're certainly trying to ring the bell for the really important work of DIS across the country. Hopefully you all received our media release that we released yesterday called "An Army of Contact Tracers Will Bend the COVID-19 Curve," basically calling for our leadership at CDC and our leaders in Congress to support expanding a DIS workforce to respond to COVID-19. So please do check out that press release, and if I will also place that in the chat. And finally, we developed a video highlighting actual DIS and their work. You may see some colleagues or people that are familiar to you. We kind of reoriented some of our old DIS videos to make it appropriate for COVID-19 response. I think it came out really, really well, and I think it really tells the story of DIS and what they're doing around the country and the unique skill set that you all have to respond to emergencies like coronavirus. We've had some great response to our video and our press release, so there will be a number of stories coming out this week that are highlighting the important work of DIS in national media outlets, and I'll be sure to share those on all of our communications outlets as well. And then finally, the last thing I wanted to highlight is something that we shared today in the Command Center alert, and that is the CDC released alternative STD treatment options for use during COVID-19, entitled the Std Treatment Options. So basically, these are intended to supplement the treatment guidelines that CDC releases every few years, and it's supposed to serve as alternatives to the standard treatments for STDs during a time of crisis like COVID. So that's a really important resource that I would encourage everyone to go check it out. And yeah, I think that is probably a good place to transition into Zant Bryan. Zant Bryan's joining us from the Washington State Department of Health, and he's our full member from Washington State, and he's going to be talking about contact tracing as a perspective from the field. Unless, I don't know, Leandra, do we pause for questions or anything, or should we transition just straight to Zant?
If anyone has questions, definitely feel free to put them in the chat box, and we can address them at the end of the call. And those resources, some of the resources that Matt mentioned, such as tellyourpartner.org/tellyourcontacts.com, and the NCSD COVID Command Center, as well as the DIS video, are all listed in the web links box. You'll see it underneath the slide. So, yeah, thank you so much, Matt. And if there are any questions that are specific to you, I don't know if you're hopping off, I'll definitely loop back around with you afterwards. But we can move forward.
I'll be on the call for the remainder, so please feel free to ask questions.
Okay, perfect.
Thanks. So with that, I'll be ready to turn over to Zant. Thanks, Zant.
Great. Thanks, Matt. Making sure, am I audible? I want to make sure folks can actually hear.
We can hear you.
Well,
terrific. Okay. Hi, everybody. Zant Bryan. I'm the HIV/STD Public Health Program Advisor from the State of Washington Department of Health. The Evergreen State, as you know, is pretty hard hit with coronavirus and pretty early. We are hoping that we are seeing some improvement and some bend to our curve. And I'll speak with you, or I want to share a few things about how DIS and other public health staff in Washington are reassigned and how we're investigating and responding to coronavirus. first point I want to make is that not all of our STD and HIV staff are assigned to coronavirus response, although a large percentage of our staff are assigned to this work, and people are pitching in from a variety of roles. And that's not just DIS roles, actually, and I'll talk about that in a moment. Staff members are rotating in and out of contact tracing as capacity and other commitments permit. But the core HIV STD surveillance and response activities continue, though at a reduced rate, as well as core program management and operations to the best extent that capacity permits. Some of our DIS are assigned to teams that are conducting outbreak prevention activities with facilities and communities, or assigned to activities that are like call centers or other types of activities where we're providing information directly to the public, because of course DIS, all of you have core skills that are really well suited to breaking down information and helping people understand it at the level at which they function. But a lot of DIS are conducting contact tracing work, and that's both state and local DIS, because Washington has both. We have local DIS who are working in teams that serve one locality or one county. We also have state DIS that serve larger regions where there are smaller or more rural counties that don't have the resources to employ DIS that are solely focused on HIV and STD. Or on other infections. In fact, as we have jurisdictions that use DIS to do communicable disease work and tuberculosis work, for example. Additionally, contact tracing is also being conducted by public health nurses at a lot of these jurisdictions, by epidemiologists, and by folks in other roles. The State Department of Health has built and trained a large core of staff from across the agency that are conducting contact tracing work so that we can handle as many cases as possible, as quickly as possible, because we did have a rather rapid jump into large numbers of cases, an overwhelming number that a small team would not have been able to handle. So in terms of how the work is flowing for us, the cases are assigned as laboratory results are reported. There's not currently a prioritization by other factors, such as risk factors, things like that, because that would require a provider case report to determine beyond, for example, age. And because of a lot of things that you can all imagine, changes to the structure of clinical services, closures of facilities, and other things, provider reporting is essentially nil right now, even though Washington typically requires a provider case report for all lab-reported diseases. Right now, that's a lot harder to get for reasons you all are already very familiar with. So we're really building our cases to be assigned from a lab that's reported, a laboratory result, and then the use of other data sources to acquire the locating information. I would use Accurate as a good example, or LexisNexis, depending on how you use it, as an example of how we're acquiring that locating information. But the cases are assigned as they come in and as they're reported, and not prioritized by, for example, location or by age or other factors. The cases are contacted in terms of sort of the effort that we're putting into them. They're contacted at least 3 times by telephone in the attempts to secure an interview. So that's typically twice within a 4-hour period. And then if we don't find them and secure an interview through those calls, then we want to move to at least 1 call after standard business hours. And if we still haven't reached you, then we're going to go ahead and close the case as lost to contact. If you're a thorough DIS like me, you're uncomfortable with that, and that feels not as thorough as it could be. This abbreviated depth of attempts to contact is really necessary due to volume. That said, we are reaching quite a number of people. I don't have an exact interview rate, but our interview rates appear to be pretty good based on what I'm hearing from DIS that I know who are doing the work. They are reaching people, and quite a number of them. If we're working on a case where the person who was infected is deceased, if it's feasible, the interview is sometimes conducted to the best extent possible with someone who would be a next of kin, if that's feasible. When we do reach somebody for interview, people are asked about the period of their lives from 14 days prior to symptom onset and then their contagious period, which is currently defined as 2 days prior to symptom onset, and then up to 16 days after that date. And so we're asking about facilities and places that someone spent a lot of time, healthcare locations that they've utilized, as well as close contacts. We're thinking about, people that they've spent more than 10 minutes with indoors. Those are the folks that we're prioritizing most highly as contacts. We also are gathering quite a bit of data. If you look at the contact tracing training that we shared with NCSD that's in the command center, we're asking about things like pre-existing conditions that might have exacerbated coronavirus infection, as well as any medications that they were taking, for example. In a lot of cases, close contacts are already found as positives from what we're finding, but those are often passed on to our local health jurisdictions by the state folks that are doing the interviews, so that local health jurisdictions can make attempts to notify close contacts not already known as a coronavirus positive. And in some jurisdictions, they've had to pull in extra staff to do that work from a variety of roles. I have even heard of, from various places, either tossed around or anecdotal stories of police and firefighter roles in some localities and project areas being pulled in to do some of the notification work, because we're really short-staffed, and you already knew that. So when we reach contacts, they're offered information about coronavirus, links to information on our website and others, and asked to contact their primary care provider. With Washington being a Medicaid expansion state, we're about 7% uninsured at last look, I think. So a lot of folks do have insurance coverage, which is good. If folks do not have a primary care provider they can identify, they're asked to seek urgent care environments where feasible. And in all cases, to call ahead rather than just go into a facility. We are not at this point referring to specific providers or to specific testing centers or testing efforts. When I've talked to DIS and other folks who are doing the contact investigations, they say that these interviews are a lot different from the interviews they typically do. The age group's very different, a lot of older folks that they're not used to talking to. But one thing that's come up repeatedly is that they're heartened by talking to people who successfully recovered from coronavirus illness. One said, I didn't expect to talk to a 90-year-old who's back to normal and healthy and who made me laugh. A lot of folks realize that people are focused on numbers of hospitalizations and deaths, which are some very dark things to think about. But that's, those are really the only somewhat reliable indicators we have without widespread testing. But DIS are telling me that there's a lot of comfort in talking to large numbers of people who have recovered. And so that's something to think about. It's also an eye-opener for a lot of folks who aren't DIS but are getting pulled into this work. But our DIS are also making clear to them that this looks very, very different from how standard HIV and syphilis investigation works and feels. Regardless, some of the DIS certainly are saying that this is helping them think through some of their interview skills as they think through how to tailor what they're saying and how they're doing their work to a different population than they might be used to. So that's, I think, in a nutshell, sort of what it looks like for our DIS and for other folks doing investigation. One question that we've had posed a couple of times also is, we have a vast number of cases, and is contact tracing actually worth it? And the way we're looking at it really, it helps us build a large body of epidemiological data that can be used to help us clarify case definitions, identify factors that influence the course of disease, and connect people and places to understand how the disease has spread in the population. People that we're contacting are comforted that public health is reaching out to them. And this is also helping us target, exposed, and diagnose people who most need information for education and prevention efforts. It's also helping us identify priority facilities for assistance with decontamination or outbreak prevention efforts. And it's helping us be more ready for long-term control once these non-pharmaceutical efforts like social distancing bring diagnoses and spread down to a level that contact tracing and quarantine can help us at that point contain it while we're waiting for clarity on effective treatments and on a vaccine. And that's what I've got. What questions do folks have?
Thank you, Zant. We'll actually take questions for you and Diana after Diana does her piece, if that's okay with you.
Works for me. Thanks.
Perfect. Okay. And I will encourage you all to continue submitting questions in the chat box. We'll definitely be keeping a queue to answer those at the end. But in the meantime, I will kick it over to Diana Pratt from the Virginia Department of Health.
Thank you, Leandra. Good afternoon. Well, in Virginia, we are still following up on syphilis cases and HIV cases, of course, especially in pregnant women, women of reproductive age, men who have sex with men. So we do have DIS working our high priority STD and HIV cases, but then we also have other DIS who are doing contact tracing for COVID-19. And the DIS make index patient calls. So when we receive a positive lab result or we receive a case report from a provider through REDCap, each DIS is basically given a list of people to call each day. And when they do get a hold of an index patient, they follow a script and they fill out a case investigation form. And they ask, what the patient did in the morning, afternoon, and evening for the 2 days prior to symptoms, as well as the 3 full days after the symptoms started. And they ask, who were you with? What did you do? Where did you go? Did you visit the doctor? Did you go to the ER, the urgent care? And they get all the information they can so that they know who to follow up on. And then they use a close contact questionnaire to call each of the household contacts and close community contacts of each index patient. They explain that if they have had any symptoms, when their quarantine would end. They explain, when they may have been exposed, and then they basically ask them about their symptoms. And when they basically just kind of ask them a lot of the same questions that they asked the index patient, but they explain that their self-quarantine would end 14 days after the last exposure date, if we know for sure what the last exposure date is. For the close community contacts, and for household contacts of the index patient, the self-quarantine would begin 3 days after the index patient has no symptoms, their body temperature is normal, and they're feeling well or back to normal. Healthcare providers who test positive for COVID-19 are actually interviewed by our VDH epidemiologists, and then the employer of the healthcare provider, whether it be a hospital, a medical center, an urgent care, contacts all of their coworkers and anyone else who may have been exposed while at work with them. And as far as referrals for testing, we do refer symptomatic patients or symptomatic contacts who are a known contact and their symptoms are bad enough to be hospitalized, but if they prefer not to go to the ER or the urgent care, they can be referred to a health department for testing. But again, they have to be symptomatic, a known contact, and feeling quite ill, because we are limited in the number of test kits that we have. We will provide notes when we ask people to self-quarantine for 2 weeks, so we will provide notes that they can give their boss explaining that they can't return to work for 2 weeks. And then when their self-quarantine ends, we'll give them another note stating that it's okay for them to return to work. And we also tell contacts who would like a test that, but they don't have any symptoms or they don't meet our guidelines for health department testing, that they should contact their private provider. And if they are feeling ill, they should actually go to an urgent care or an ER if they're feeling quite ill, because, we don't want to inundate our ERs and urgent care centers either. So we just basically provide a lot of information. The forms that we fill out are quite lengthy. The case investigation form is 11 pages, and it basically asks for demographics, their medical history, their symptom onset date, if they've been self-isolating, when their isolation started. We go into quite a bit of detail about, their temperatures, if they have them, many different symptoms, many different chronic infections to determine what their risk factors are for, needing more intense follow-up. We also we actually go back the full 14 days sometimes if needed, if some people are really good historians. We will go back as far as we can, and like Zant said, that's the DIS in us, but it does get time consuming. So there are some people who say, no, I can't talk this long, or just ask me the basic questions. I don't want to be on the phone for an hour. So we get as much information as we can, and we are working to enter all this information in VEDS or NEDS, because we currently use REDCap, but we also use a spreadsheet for each health district, and it's just getting to be obviously too much information for spreadsheets. But that was something that our EPI department decided to do. And then we also have calendars that we use for January, February, March, April, May, June. We try to make it a lot easier for people to remember things by going back. Same thing DIS do when they're interviewing syphilis and HIV patients. We talk about holidays. We talk about weekends. We try to encourage them to remember certain things based on the time of day and the time of the month and that type of thing. And then the close contact questionnaire is similar, but it's actually shorter. And if one of the close contacts tells us they've actually tested positive, or they've actually had severe symptoms, or they know that they're positive for some other reason, then we may actually fill out the close contact questionnaire and whatever information is missing from the case investigation form, actually kind of do both at the same time, but of course not duplicate questions. If someone has passed away from COVID-19 or complications from COVID-19, our EPIs will actually do those calls to the patient's, spouse or adult child or parent or that type of thing. And those ones, if the EPIs aren't comfortable with that, then we do have a few DIS who are more comfortable with that, or DIS supervisors, because we do want to notify, of course, all of the household contacts of their risk, but then we also want to find out more information and get the information that's required for the CDC, because the CDC wants to know a lot more information about those who do pass away with complications to COVID-19. So the close contact form, like I said, it pretty much includes the same thing, demographics, any symptoms, any medical history that would be relevant, whether or not the person is a smoker, and if they are asymptomatic, then we have to determine how much risk are they at, and just kind of let them know what symptoms to look out for, and when they should go in for a test if they do develop symptoms. And that's all I pretty much have. I know we're only supposed to talk for about 10 minutes, so.
Thank you so much, Diana, and also to you, Zant, as well. We've gotten quite a few questions in the chat box for both of you. The first two that came through were actually about surveillance. So John asked, is EPIC's data available to help with the investigative process? Do any of you have any insight for that? Brandy, you're also welcome to chime in as well with your perspective from Arkansas. It's definitely valued here too.
Okay.
This is Zant. I'll jump in on that one. Where we have access, typically our local health jurisdictions are the folks who have access to electronic health records through things like EPIC. Where we have access for that, yes, that kind of access is being used to gather information where possible. The volume makes that a little bit more prohibitive, but we're doing our best.
And in Virginia, we do have some of our HIV surveillance officers who have access to certain EPIC systems, for hospitals and some of our biggest providers, but it's very limited, and so we don't have them look up every single case. But if we do have someone that we haven't been able to get a hold of, or who has passed away, or who we know is very, very ill, but perhaps isn't able to speak and doesn't have anyone in their immediate family who could speak to us, or maybe even the provider doesn't have that much information, yes, we will ask our HIV surveillance officers to do research and get as much information as they can related to the questions that we're missing information on.
Great. Thank you. Jesse asked if this was, wasn't sure if this was addressed already, but is there surveillance in relation to HIV and COVID? And I know that one of you brought up REDCap. I don't know if that could help answer this question, and I don't remember exactly brought it up.
Diana mentioned that Virginia is using REDCap. We are also using REDCap to document data from our interviews at this point. I know that our state surveillance, our state HIV epidemiologist is looking into doing a match between coronavirus diagnoses and our HARS database, but I don't really know anything more than that. I don't know if it's occurred. I don't know what the results are. I don't know what the barriers are to that, but I know that there's interest in looking at the overlap between the two.
Great, thank you. Sarah asks, what, if any, lag time is there from your time of receiving the test and the interview? For example, have people gotten through their 14-plus day infection period?
No, not in Virginia. As soon as we receive the positive test result, we are following up on them. So we have staff working up to 7 days a week. We have staff working Saturdays and Sundays. We have them working mornings, afternoons, evenings, and we are right at this point allowing people to volunteer because we're paying overtime. So a lot of the DIS want to do this on the weekends and nights, but then we're also reminding people to flex out time whenever possible and to rest and that type of thing. So as soon as we get the result, we try to call them the same day, and if not the same day, then the next morning.
We're playing a game of catch up in Washington. We were obviously early adopters with coronavirus, yay. And so we're getting to everything as quickly as we possibly can. But that does mean that for some subsets of our cases, they were already out of that period by the time we got to them. But I think we're going to get ahead of the curve fairly soon as our diagnoses start to drop and our hospitalizations start to drop. And I think we may reach a point of parity where we'll be just like Diana describes, where we would be following up on folks. We're attempting to follow up on folks just as quickly as they are reported.
Thanks. Gonzalo asks, what is the plan for contact tracing in regions with a high number of homelessness? These are some of the hardest to follow up in syphilis investigations and usually require more time and resources. Any insight there?
Amen to that. We have a lot of syphilis in a couple of areas of the state in Washington in populations like this, and it is very difficult to do that work with folks who are unstably housed and whose access to technology is much less. In some cases, what we've received is a lot of requests from facilities that house and serve this population on how they can conduct better infection control, on guidelines for how to work with the population around prevention and around building ways to serve folks who may be ill or may be afraid of being ill in these types of facilities. That's really the best I've got at this point. I don't know that we're far enough along to say that we've got a good answer for this down.
And in Virginia, what's happened so far is that for the most part, any homeless men or women who have entered the ER and had symptoms of COVID-19 tested positive for COVID-19, so far we've been lucky that they've all had cell phones. And because we're not making field visits on them, it's a lot easier for us to get a hold of them over the cell phone. And we are actually using phones at the local health departments for the most part. So when someone calls them, they'll actually see that it'll probably, say Peninsula Health Department or Hampton Health Department or that type of thing. So they're more likely to answer. With our DIS calls for syphilis and HIV, we don't usually do that. But in these particular cases, we've been told that they really want people to answer the first time you call or know that it is official and it's not a scam call, and we need to get a hold of them right away. So we've been pretty lucky in that way. We've also had, ERs and urgent care centers who are used to dealing with homeless persons who often will ask them some of the questions and then let them know that the health department will be following up with them and asking, they ask them to please work with us because we're just trying to help and stop the spread.
Thank you for that great question, Gonzalo. Trina asks, are you conducting a secondary test for individuals who have quarantined/isolated themselves after 14 days or are asymptomatic?
No, we are not.
Okay.
Are we even testing asymptomatic people at this point? I mean, at this point, I think only the people with the toughest symptoms are getting the tests. Not even everybody who's symptomatic is getting tested. I mean, if we could have more widespread testing, I think that's a great idea. But I think lots of folks know where we're at with that, and I'll just keep my mouth shut and stay off my soapbox.
Dan, you're so funny. This is Brandy from Arkansas. We're actually not conducting tests either unless they're in the hospital. But if they're home, they're pretty much just, just assessing if they've been, without a fever for about 3 days and without symptoms for 7 days. But we pretty much just don't have the time to actually do a secondary test afterwards.
Thanks for that insight, y'all. Rachel asks, do DIS use resources such as Accurate to find additional information on contacts if the infected individual doesn't have any locating information such as a phone number?
Absolutely.
Our DIS don't have access to it, but our regional ST program coordinators have access, as do others in our central registry unit. So the DIS can actually call and just ask them to look it up, and then they share the information with them. And the reason for that, we just don't have enough funds.
A lot of stuff, and I gave her the whole bunch of shit.
So we just don't have enough funds to have all the DIS have access, unfortunately, but they're able to get the information very quickly.
Yeah, and I don't know if somebody needs to mute their phone. But this is Brandy. To add to this, so our DIS currently are not working COVID response. However, our epidemiologists are, and just so happen, two of them are two of my former DIS, and they have found it useful to use those resources to contact those individuals where they don't have a lot of information. So we do have access to like our WIC database, DMV database. We don't have Akron, but I think we have like Spokio that we use, and that has been helpful as far as them locating individuals, especially from our commercial labs where they don't send in a lot of information for us to contact those individuals.
Great, thank you. The next question comes from Edwin. Edwin asks, is there guidance as to abbreviated interviews, most important questions to ask of someone who doesn't want to take time to do a full interview?
Well, we have, in our forms, we know that sometimes people won't want to talk. Like I said, they won't want to talk for as long as it takes to fill out the 11-page form. But we do ask them at the beginning, we try to start with things that will be very interesting to them, such as their symptoms or their being exposed. And we do try to go quickly, but at the same time, if they want to share a lot of information, we'll let them talk as long as they want. But we do have, we do prioritize the questions, so we do try to focus mainly on the demographics, the symptoms, and their contacts. And so if they say, no, I've been alone in my house for the last 2 weeks, or, we can cut certain things out based on their answers. So, and we have a script for the DIS to follow so that, it'll say if they say no to this, then go to this question. If they say yes to this, go to this one. So, it shouldn't take as long for patients who don't have as many exposures or symptoms or that type of thing.
And ours is thankfully not 11 pages. Wow, y'all. And because of the volume that we have, our training and supervision has really emphasized the need to complete interviews in a time-efficient manner. And so it's generally hoped that our DIS are going to keep that conversation to 10 to 15 minutes or so. And it's also partly a recognition that some folks are still sick. Some folks are still really fatigued and exhausted from being ill and are still recovering when we speak with them. And having been really sick before, I can say I can understand that having a conversation like that can wear you the heck out. And so the idea is, because we have so many cases to work, we've kept our data collection relatively abbreviated and sort of most need to know. And I think Diana really identified what those things are too. And tried to keep it efficient, both in recognition of what it might be like for the patient and in recognition of the volume of work that we have.
Yes, and I would like to say too, we based our questions mainly on what we know the CDC is looking for, but 3 of the pages are basically breaking down the patient's symptoms into 5 days after the illness. I mean, we'll go back as far as they can, but if they don't have any information, like if they don't have symptoms, that cuts off 3 pages. And if they don't have any contacts, let's say, that cuts off 2 pages. So, we may have somebody who, let's say it's an elderly person, they live alone, and the only place they've gone in the last 2 weeks is they went to one doctor appointment, and they were the only person in the lobby, and the only person they spoke to was the doctor, or whatever it may be. So it is a really long document, but for the majority of people, it's probably cut in half. And then for the close contact questionnaire, that's actually 4 pages, because the other 2 pages are the calendar and then kind of a script, like how you start the conversation and how do you end the conversation and what do you do, if they start to cry or, that type of thing, because we know some people aren't used to that, especially the newer DIS who haven't done as many in-person investigations. So a lot of this is kind of new to them.
Okay, great. Thanks, Diane and for that. That was great information. So on to our next question from Jessica. So can you explain the statistical data that shows that the next 2 weeks will be worse than the last 2 weeks, or is that an estimate? I think that was Did anybody want to speak on that question?
I don't know that I'm going to preface this with I'm not an epidemiologist, so I don't think that I think it's going to vary from state to state based on what we've seen and how early we started and how fast things have exploded. I think really they're just going on data that they have from hospitalizations, because we have syndromic surveillance data that can help us look at influenza-like illness and hospitalizations and things like that, and we can see those things increasing, and we can see when those things appear to be leveling off, in addition to the really incomplete data we have about diagnoses and of deaths. I think those are the data sources that they're using, among other things. The University of Washington's been conducting some fairly complex modeling using data from other countries and their experiences as well. And that's about as much as I would add to that, because I don't know that I'm qualified to say anything else.
Yeah, Dan, pretty much same here. Because us, like you said, that it kind of just depends on the testing that's been done. I know here in Arkansas, we're constantly adding on additional labs and commercial labs that are testing. So sometimes it seems like it's getting worse and our numbers are increasing. But at this time, it's kind of hard to really tell or judge, because I agree. We don't have, it's delayed for one thing, and then, we just don't have that information as of yet, and it varies from week to week. So it's just an estimate at this point for us as well.
Right, and I think that the reason why the federal government is saying that is they've looked at other countries, and they basically kind of followed that and looked at the methods and everything, and they've basically discovered that there is that peak, and so it looks like we may hit that peak, is what they're saying, and where the next 2 weeks will be our highest numbers yet, and then after that we'll start to go down. But they're also saying that there are probably a lot of people who maybe will be tested more, because there are more tests available, and now there are rapid tests available, and there's a lot more reporting going on, and there's a lot more of the contact tracing going on, maybe. So I think numbers will go up that way, just because more people will be tested and more results will be reported, and
right.
And then after a while, once they have the vaccine, or we have like herd immunity, then I'm sure the numbers will start to go down by a lot.
Right. I agree. Gotcha. All right. Thanks. Okay. So for Michael, the next question we have on the chat, overtime was mentioned, but in instances where face-to-face interviews are conducted, is hazardous pay eligible eligibility considered for the DIS for Arkansas, that is a no. And Diane, I guess I'll add on that one as well.
Yes, that's a no for us too. We do pay time and a half for every hour over 40, and we don't do hazard pay because we do almost all the interviews over the phone. If someone does have to go out to someone's house, we have them knock on the door and then they actually back up 6 feet, which I know sounds kind of silly, but it's rare that we have to go out and do a face-to-face interview. And then we basically ask them to give us a call. You know, we'll say like, okay, I'm from the health department or whatever. I'll leave my business card on your porch after you close the door, but if you could please call me. So they kind of let them know a little bit there after they verify their identity, but they don't do a face-to-face interview unless the person were to say they don't have a phone or a working phone or that type of thing. But we also set up accounts with Doxy.me now, so we can actually text a video call to a patient or a contact. And, you know, if we haven't been able to get a hold of them by phone, or if they have a text-only phone plan, or let's say they don't answer their phone or they don't check their voicemail, we can send them a video chat invitation. They just click on that, and then they can see us and we can see them, and we explain who we are and why we're trying to contact them. We verify their identity, and then we can do the interview that way.
And I'm going to say we are not doing face-to-face interviews.
Okay.
To my knowledge, that is not occurring for us.
Okay, gotcha. All right. So from Gayon, if I'm saying that correctly, is racial data collected for Arkansas? Yes, and that information is posted on our website. I think we're at about 960 cases right now, and I believe the majority of those are white, about 70%, and then the rest of them are black. So we are collecting racial data and also age information for our positive cases here in Arkansas that is posted. So Zant and Diane to add to that?
Yes, we are in Virginia as well. Hey, Garyon. I know Garyon calling from Florida.
to my knowledge, we are also collecting data around race, but I don't know what our statistics look like at this point.
Okay, and I know the next two individuals asked about a DIS script. Do we already have something like that on our website, Leandra or Matt, DIS script? Or
I know that Amon just posted an example from our COVID Command Center. I think it's actually from the Washington program. And I do encourage you all to definitely explore the COVID Command Center. The resources are divided into DIS, STD clinics, different populations. So I definitely encourage you all to check that out and look into the DIS resources there, and you can find examples there for scripts.
Gotcha. Cool. All right.
And Matt or Amon, sorry, I was going to say Matt and Amon, if you have anything extra to add, definitely pop in if I missed anything.
Leandra, I'll send you everything that we have, our close contact and case investigation questionnaires.
Perfect.
And our recommendations. I'll email you all those.
And are we able to post that on the Command Center widely?
Yes.
Okay, thank you.
Okay, and I know we have a few minutes left, but we have a few questions left. So from Shaniqua, has there been a decline in your STD, HIV cases in your cities, and that's due to providers being closed? So for Arkansas, yes, just because we did have have a couple of our local health units that closed, so we are now not seeing that many cases. However, we aren't able to judge that at this point, but just from kind of looking at it, since we've closed down some of our local health units, we have had a decline in our cases.
We have too. In Virginia, there's not as much testing going on at the health departments, so that's definitely reduced our numbers. And then there are a lot of private providers that are closed or are only seeing people for urgent needs. So.
And I will say in Washington, we're experiencing some similar changes to how many cases we're seeing reported. I think that has to do with lots of things. If you look at the STD, the DSTDP or CDC Dear Colleague letter that came out yesterday discussing syndromic management of symptomatic STD cases. In other words, choosing to treat potentially with or without testing, depending on what's possible. I'm sure that is influencing it a lot. There are a lot of things that are there are a lot of things that are going to be influencing whether or not providers test, and we're dependent on lab reports for a lot of that. So we may not have as many confirmed cases this year if people move to doing a lot of empiric treatment or presumptive treatment of cases. And that's something that we're expecting, and we're thinking about how to potentially have probable case definitions or things like that if we need to. It's going to be pretty weird for our data.
Yes, I agree. Okay. All right. And quickly, I guess, Diane and Zant, you can probably answer this briefly, but what is your process for screening contacts from John on the text?
Well, we do actually screen them over the phone, and then if they do have symptoms, we recommend that they go to their private provider. If their symptoms are really mild and they don't really feel like going to the doctor, we just ask them to self-quarantine for 14 days, from the date of the onset of their symptoms. But I do see here a question from Lori Foster where she had a friend in Virginia who was told she couldn't get tested because she didn't meet the criteria that the CDC had dictated. And it is true. I mean, we have a lot of worried well calling the health departments and calling our central office and just wanting to get tested just in case to see if they have it. And we're not offering tests for that. And like I said before, our local health districts have a limited number of tests that they can do. So, we have to limit that. It's true. I mean, if her friend had symptoms, we would have offered a test, but I know private providers are even not testing every single person because they're finding a lot of people with allergies and regular colds and regular flu or pneumonia who insist they have COVID-19, but they don't have the actual specific symptoms for COVID-19. So now that our testing capabilities are expanding, we're hoping that we can test more people. And once the rapid tests are fully available, I think we'll be able to test a lot more people, but we haven't been able to test everyone who's wanted a test, that's for sure.
I'm going to sound like a broken record. We don't have the ability to test everybody at this point. People are being referred when they're notified of exposure to, in many cases, to contact their primary care provider and take it from there, or an urgent care if they don't have a primary care provider, and to call ahead and see what their care provider recommends based on the symptoms that they have. We're letting the medical care system handle that very frequently.
Gotcha. And that's same here from Arkansas. We even have it where, they have it where you don't contact your private provider until you're having breathing problems. So even if you are having some, some minor problems, they want you to kind of try to manage it at home. And then if it gets serious enough to where, you're having problems breathing, that's when they want you to contact your medical provider. As Zant mentioned, we're doing the same process here. All right, so I think that wraps it up for our questions. Leandra, did you have anything else to add? I know we're getting close on time.
No, I didn't, but I think we have a couple more minutes. I'd be willing to take a few more questions before I do my spiel about all of our NCSD resources that I've mentioned. So if there are others, definitely feel free to put them in the chat box. You can even press *# on your phone as well to unmute yourself to speak over the phone. If you want to speak your question, that is also fine. I saw the question about the text-to-video chat program. Thanks, Diana, for answering that. The doxy.me for the text-to-video chat program. So thanks for answering that in the chat. There was another question from Shanique. She said, how can I access the Dear Colleague letter? I think, Zant, you may have mentioned this.
Have we posted that in resources on the NCSD website? Because it seems like that would be something that we'd want to do.
That's a great question. And if not, we can. Sure.
I'm sorry, this is Matt. And are you referring to the treatment options, Dear Colleague?
Yep.
We have the treatment options on the website. I'm not sure that we posted the text of the Dear Colleague, but we can certainly do that.
Thanks, Matt.
Hi, can you hear me?
Yep.
Yes.
Oh, hi. I tried
posting a question in the chat box, but I'm too technically deficient. I wasn't able to figure it out. My question is, we're all DIS, and so we follow really strict confidentiality rules for good reasons that come down from the CDC. So I was just wondering, in my program, we're just starting to reach out to the local health departments to see if they want our assistance with contact tracing for COVID. Have you found that the confidentiality rules are the same when it comes to accessing PII? For example, if we all want to work from home, and we're not currently allowed to work from home as DIS, doing STD and HIV work, but are the confidentiality rules different when it comes to COVID versus HIV and STD?
Thanks for your question. Where are you calling from? Sorry, I just want to get your location.
Oh, my name is Bridget, and I'm in Buffalo, New York.
Okay. Hi, Bridget. Sorry.
Hello.
This is Zant. I'm going to jump in and say that I actually questioned this in our first contact tracing training, and pushed to make sure I understood. Confidentiality rules remain the same. Protected health information is still protected health information. We do have DIS who are permitted to work remotely, and we are, because there are such strict rules around social distancing and so on and so forth for Washington, a lot of people are working from home. With appropriate safeguards, we are allowing people to conduct contact tracing while working from home.
In Virginia, we are also, previously DIS were under a class of employees that were not allowed to telework, but we received an exemption. So a lot of our DIS are now teleworking, and we just make sure that they have their state cell phones, they have their laptops, and like Zant said, they follow, they're very, very, they have to follow strict rules when they are teleworking, especially if they have a spouse at home or a significant other or, teenage children or anybody like that. And so it was probably difficult for some of them to get used to being at home, but they all have locking cases. They all know what to do with their confidential information. And as far as COVID-19, the DIS treat the information the same, but I do notice that at some of the local health departments and some of the epidemiologists themselves who are used to dealing with foodborne outbreaks and that type of thing, they're not quite as strict maybe as we are with our confidential information, but it's because they're used to being able to say, did you eat at this restaurant on this day at this time? And, they're used to being able to share certain information that we're just not really used to sharing. So as far as our DIS go, though, any patient information or contact information is very, well protected.
Great. Thank you so much. I do want to give another special thank you to Zant and Diana and Brandy as well for this great call. There was some engaging discussion here around contact tracing and just great sharing of resources as well. I do want to make sure that I point out this web links box that's underneath the slide that you're looking at. So in this box, there are links to many different resources, one being the COVID Command Center that has been mentioned already, with tons of resources there. I also will point out the DIS Slack workspace that NCSD has. This is a place for you to connect with other DIS across the country and just another platform for you all to continue this conversation and share ideas and share resources and share perspectives from the field. I'll also point out the DIS redeployment survey. So NCSD really wants to make sure we're taking a pulse of how DIS are being used with COVID response and how well you all are able to maintain your current STD workload in the midst of COVID response. So I ask that even if you have filled out this survey before, if there are any updates in your jurisdiction, please fill it out again so we can stay updated. You'll also be directed to the survey automatically once this webinar closes. There's some other resources here that were mentioned, like the DIS video, the press statement around contact tracing, different materials from Washington State with their contact tracing resources. That their colleague letter is also listed there. And again, these resources are also listed on our COVID Command Center. I have Zant, Diana, and my email addresses listed here on the slide if you want to reach out to any of us. This meeting will be recorded. It is being recorded, as I mentioned before, and it will be shared with all of you, so be on the lookout for that. And also be on the lookout for information for next Tuesday's call. Again, it'll be at the same time, 3:15 to 4:15 p.m. Eastern.